Greeting everyone. I am Dr. Deependra from Conceptual Orthopedic, and I welcome you all in today's connect session with Ashish sir. And today sir is going to discuss overview of shoulder arthroplasty. So I think this talk is going to be very useful to all of you. So without any more delay, I welcome you sir on the board, and I request you to start your presentation. Now it's over to you, Dr. Ashish sir.
Thank you. So today we'll talk about shoulder arthroplasty. Shoulder arthroplasty is the new thing, a new topic, which is now getting more and more into practice. So I'm sure this will be asked more frequently now, both in theory as well as practicals. So I'll give you overview of arthroplasty. We'll go on to details as we go on with next lectures. So what all arthroplasty do we normally use in our practice? So it can be different types of arthroplasty. We deal with hemi-arthroplasty, then there is anatomical total shoulder arthroplasty, then it's a semi-constrained reverse shoulder or inverse shoulder. So these are the three types of arthroplasty that are commonly being used in today's practice. So we should know the indications, exactly when do we need oh my god, 1 second, yeah. So we should know our indications well, that when we should be able to use which operation. In terms of hemi-arthroplasty can be done for a AVN patient of humeral head, provided the glenoid part is intact. So it is like a bipolar of the shoulder, hemi-arthroplasty of the shoulder. Just because it is not weight bearing, so we can expect hemi-arthroplasty to do well in shoulder, because the glenoid will not be affected that much, because it's not a weight bearing joint. So hemi-arthroplasty can be considered for patients of AVN in which the glenoid is still intact. So this is very important, that head may be deformed, but the cartilage is intact. You can consider for hemi-arthroplasty. It can also be used in osteoarthritis, in which the glenoid is very deficient, in which you cannot expect to have a good stable glenoid fixation. In that case, it can be a salvage procedure also. And usually we use it for a comminuted osteoporotic proximal humerus fracture, which is not amenable to osteosynthesis. So you have to understand the three main indications for a hemi-arthroplasty will be: one, a bad trauma of proximal humerus, which is not amenable to fixation; two, AVN of humeral head, in which glenoid is still intact; and three, in as a salvage operation in which the glenoid cannot be reconstructed. So these three are the main indications for hemi-arthroplasty. So whenever you have a case like that, be sure that you advise or you offer options as per the indications. The most important thing about hemi-arthroplasty that you have to understand is, you have to ensure that the tuberosities come back properly. If there is one mantra for successful hemi-arthroplasty, it is the reconstruction of tuberosity. If you do not reconstruct tuberosity well, that hemi-arthroplasty will not do well. That hemi-arthroplasty will not have a appropriate outcome. The patient may become pain-free, but the movements will be really restricted. So if you want to have a good function or good outcome of hemi-arthroplasty, you have to ensure that your tuberosities are sutured well. And this you will know that you have to have a plan of fixation of your tuberosities. It's a very complex way of fixing the tuberosities, but you should be prepared. That should be your main plan, how we will reconstruct the tuberosities. In in shoulder arthroplasty, the main thing is to dial in the right version of the humerus and to get the tuberosities come back at the right place at the right height. So these two points are the most important for a successful outcome of hemi-arthroplasty. Then we have a total arthroplasty. Total shoulder arthroplasty, as you can see, it will appear like this. It will be a all polyglenoid with a metallic head over a metallic stem. This is your total shoulder arthroplasty. Nowadays, there are some newer designs also, which may be stemless. So it can be a stemless or a stemmed humeral component and a all polyglenoid. This is how our total shoulder arthroplasty will look like. It is mainly indicated for primary and secondary osteoarthritis as well as early RA. These will be the main indications for a anatomical total shoulder arthroplasty. What is the main prerequisite for a total shoulder? A intact rotator cuff and a good glenoid where you can put your glenoid component on. These two are the most important prerequisite for a total shoulder arthroplasty. Intact rotator cuff and a good glenoid to put your glenoid component on. So as I said, it has an all polyglenoid component. It can be of two main types. It can be like this with 4-peg glenoid, or it can be in the form of a keel. So there are different components which have different ways of anchoring the glenoid component. Keel or plug, both are good in terms of stability. Now, the arthroplasty which is in fashion is the reverse shoulder arthroplasty. It is a semi-constrained version, mainly used for cuff tear arthropathy, in which the the rotator cuff is irreparable and there is painful loss of shoulder function with or without glenohumeral arthritis. So, first thing is the cuff should be torn and irreparable. There will be superior migration of the humeral head and there will be painful loss of shoulder function. Plus, there will be arthritis as well. You can offer a reverse shoulder arthroplasty to a cuff tear arthropathy patient even without arthritis also. So in this is showing a normal shoulder. This is your anatomical total shoulder and this is your reverse shoulder. So this is what you should be knowing about the three types of arthroplasty in shoulder. Indications of a reverse shoulder will be one, cuff tear arthropathy, in which there will be severe glenohumeral arthritis with superior escape. So this is what happens. So what do you mean by superior escape is when this is your if this is your shoulder, so the humeral head will be somewhere here. Humeral head will be superiorly migrated and the acromial humeral distance will be decreased. This is called superior escape. It happens because the rotator cuff here is torn and it's not there right now. It is proximally retracted. So the space is there. So head tends to escape superiorly. Then the other indication of reverse shoulder is pseudo-paralysis, which means there is inability to elevate the arm in presence of pre-passive ROM, which means that we can do a passive range of motion, but there is no active range of motion. And there is no neurological lesion which has been seen. It is mainly because of irreparable rotator cuff with or without glenohumeral arthritis. Then the other indication is anterior superior escape because of incompetent coracoacromial arch. Other indication will be proximal humerus fracture in elderly